The following podcast is part of a certified educational activity titled Immunotherapy in the Treatment Arsenal for Small Cell Lung Cancer and Managed Care Implications for the 4 Ps: Patient, Provider, Pharmacy, and Plan. Access the entire activity and complete the post-test at peerview.com/TMR860. Downloadable slides and practice aids are also available. Thank you for listening to PeerView Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Hello, everyone. Thank you for joining us. It's a really exciting time in small cell lung cancer where we have significant amount of innovation for immunotherapy in the treatment and arsenal of small cell lung cancer. And today we're going to be talking about the implications for a patient, provider, pharmacy, and of course in the managed care setting. For our faculty, today's faculty, Dr. Stephen Liu from Lombardi Comprehensive Cancer Center, Georgetown University, and then myself, Bhavesh Shah, I'm from Boston Medical Center. And in regards to the agenda today, we have several topics. Obviously, we went through the welcome and introduction, and then 2 main objectives are really basically Dr. Liu focusing on how we have actually transitioned from chemotherapy and radiation to innovative therapies such as immunotherapy in the really shifting the treatment paradigm for small cell lung cancer. And then my goal was to kind of talk about the implications from a health system perspective, provider, patient, and managed care setting. So I'll be taking on the second part of the lecture. And then of course we have the audience Q&A afterwards, and then summary and reflections, take-home points. With that being said, I'm going to hand it over to Dr. Liu in the first part of the presentation.
Thanks, Bhavesh, and thanks for joining us today. Small cell lung cancer it's not a rare disease, but it is an uncommon subtype of lung cancer, accounting for about 13% of new lung cancer diagnoses. This is a cancer that spreads very quickly, very little role for surgery in the treatment of small cell lung cancer. Most patients, unfortunately, metastatic or extensive stage at the time of diagnosis. Even those picked up at an earlier stage, very likely to recur and spread to distant organs. The treatment for this, the backbone of therapy, really is chemotherapy. And it's not particularly new chemotherapy. We use platinum etoposide that was first introduced for small cell lung cancer in the 1970s. And it's a relatively well-tolerated chemotherapy. I think at first blush, it seems like a good treatment. The response rates are high, about 60%. They're relatively rapid. And about 10% of patients will have a complete response. But in reality, this is not a very good treatment for cancer. The relapse rates are just as high. The responses that you see, even complete responses, are transient, with a progression-free survival of about 4 months. Now remember, that's measured from the time that you start treatment. So most patients will progress either during chemotherapy or shortly after chemotherapy. If you look at these Kaplan-Meier curves from the initial platinum etoposide studies, you can see the vast majority of patients are not surviving even to a year. This is a standard treatment for small cell lung cancer, and despite these poor outcomes, this has been our standard since the 1970s and 1980s. We have not been able to improve on a platinum etoposide backbone. It's not for lack of trying. There have been dozens of randomized phase 3 trials that have simply failed to improve survival. For a compound to get to the phase 3 setting, it needs to show tremendous progress, a lot of investment. We have gone all the way to the finish line for many of these studies and simply not improved outcomes. And there are a lot of challenges to drug development for small cell lung cancer. Now, this is a smoking-related cancer, and so patients often have smoking-related comorbidities and may be too ill for certain types of therapy. It is a relatively rapid course. Patients typically noting symptoms only for a few months before a diagnosis. This is a cancer that moves quickly, and so screening is very difficult to do. Standard chemotherapy is fairly easy to administer, and so centers with specific specialties and research in this area, such as our two centers, we may not get referrals because the chemotherapy may be started at an outside hospital or at a smaller practice. And frankly, there's a limited understanding of the biology for small cell lung cancer, in part due to the scant tumor specimens available for study. In addition, the preclinical models on which we base a lot of our therapies simply are flawed and may not reflect human biology as much as we'd like. This is particularly true for small cell lung cancer, and it's really hindered progress. Where we finally saw advances was in the development of immunotherapy. And going in, there was a lot of rationale as to why immunotherapy could work. The early signal was that immunotherapy seemed to be more effective for carcinogen-related cancers, small cell lung cancer very closely related to smoking. In addition, we know that small cell lung cancer has a high rate of somatic mutations, and a high mutational burden or mutational load also seem to correlate to response to immunotherapy. So going in, we thought we were going to see response. We thought this was going to be an active drug class for small cell lung cancer. And now that we've got some decades behind us, we can say that, well, there is some activity, but I think it's somewhat modest. The two classes where we've seen the most activity in solid tumors have been targeting the PD-1, Pdl One pathway, with antibodies targeting either ligand or receptor, and the CTLA-4 pathway.
So interestingly, Stephen, I had a question about, we are in interesting times. COVID has definitely changed the way we practice things. And, if you've attended a conference, it's been pretty much virtual, all the conferences that you've attended. So I had come across this interesting paper from the COVID Cancer Consortium that was presented at AACR, which basically talked about higher mortality for patients who had cancer and had malignancy, and of course, especially higher for patients who had lung cancer. So I wanted to know if your perspective, if you've actually seen that in your practice, or do you have any guidance for providers who actually have seen this data, where is PD-1 and CTLA-4 basically having COVID on top of that and having lung cancer, are those patients at increased risk of higher mortality versus patients who are not on that therapy?
The mortality risk that we've seen in lung cancer has been higher than other cancers, and it has been consistent. In both the consortium papers that you'd mentioned, the International Teravolt study, reports from Memorial when New York was really hit hard, the numbers have been high, but they've been consistent. Patients with lung cancer do seem to be at greater risk. And because this is something we're living through now, we're constantly asking ourselves, are there ways that we can modify our practice to better protect our patients? Maybe not from infection, but from complications related to that infection. Certainly reducing the risk of infection is something that we've both done. And I know Boston was really hit hard at times. And keeping patients out of the hospital, out of waiting rooms, maintaining distance, strategies within our cancer center to be sure that patients that may be carriers or may be infected are not spreading that infection to other patients, caregivers, and faculty and staff as well. In addition to reducing the risk of exposure, we wanted to ask ourselves, were there ways that we can modify our treatment strategies? And when we saw complications related to COVID, and you and I have both seen these patients, it seems like an overwhelming immune response, right? It seems like a cytokine release syndrome where patients get quite ill. And there was initially some concern and some preclinical rationale as to why immunotherapy could exaggerate that, could make that worse. And that was certainly a concern here. The data have shown differently, but initially we were worried. And I'm not sure if you had the same concerns. Your area hit among the highest in the country. Did you have similar concerns about the use of immunotherapy?
No, that's a great question, Stephen. We were definitely concerned, and we were looking for guidance. European Society of Medical Oncology had put together guidance. NCCN had put together guidance. So we were really in the initial stages, and I think the other thing I would say is that I think COVID that we were treating before was much different than COVID we're treating now, where we actually have more treatments that are approved for COVID. And we actually know how to manage COVID better. So I think that there's probably differences in management that's also leading to some of the mortality that we had seen in lung cancer and other malignancies. So I think that what we definitely need more fresh data from COVID and malignancy to really make decisions in how to manage the patients appropriately. And then the other thing I'd like to mention is that we actually have a clinical trial with etoposide in our institution, which is an investigator-initiated study specifically in patients with COVID, where we know that there is this cytokine release syndrome and this ARDS that happens in severe COVID patients. And so we actually identified in our autopsy series is that basically this was an HLH type of picture. It was confirmed from these SARS-CoV-2 autopsies that we did. And so we initiated this study, and it'll be interesting to see the results. But obviously it's too early to say anything.
What we've seen so far from these data, and you're right, these data need to be looked at in a special way, but targeted therapy did not seem to confer greater risk or mortality with COVID infections. And fortunately for us, out of the most recent data set from Memorial, the use of immunotherapy, either immediately before infection or up to a year before, didn't really seem to predict mortality either. So based on those data, we do feel it's safe to use those modalities in the setting of the pandemic. There was some increased risk in some of the registries, like the TerGolumab study, with recent use of cytotoxic chemotherapy. But again, the early mortality numbers may not be totally reflective of the current state of things, especially in the US. And so those data will continue to emerge. Our general strategy in lung cancer has been to not compromise care. If patients need a specific therapy for their cancer that is far and away better than the other treatment, that we should use that to really not trade the potential risk of COVID complications for the very real and current risk of their cancer. And when we look at immunotherapy in lung cancer, again, the main pathways we're engaging are PD-1, Pdl-1, and CTLA-4, slightly different, but along comparable pathways, both having an effect on T-cell inhibitory signals. CTLA-4 a bit more in the priming stage in lymphoid tissue, the PD-1, Pdl-1 interaction more in the tumor microenvironment, targeting the T-cell effectors. But these have really changed oncology in general and small cell lung cancer. And so our current landscape in small cell lung cancer actually, for the first time in many decades, looks different, where we're implementing immunotherapy in the first-line setting. In the second-line setting, we have some immunotherapy options and the use of lurbinectedin recently approved. And in the third-line setting, we have immunotherapy drugs approved in that setting. So I think it's useful to sort of go through how immunotherapy has been working in small cell lung cancer in this relatively short journey. I think our first large experience with immunotherapy in small cell was the CheckMate 032 study. Now, this was a non-randomized trial for patients with previously treated small cell lung cancer, in many cases, very heavily pretreated. So these are very select patients, and they received nivolumab alone, nivolumab with ipilimumab at various doses and schedules. And it's showing that responses are there. Somewhere around 10 to 20% of patients are responding. The progression-free survivals were modest, but the survival rates were impressive. The median PFS in this study for nivolumab alone, for example, 1.4 months. I think we both agree that's not very impressive. It's really the first scan. But the one-year survival rate of 33% tells us that some patients are getting substantial benefit from these agents. Now, it's important to point out that this was a non-randomized trial. And it's not valid to compare nivolumab versus nivolumab and ipilimumab. What we draw from this study is that some patients receiving these checkpoint inhibitors are still alive 1 and 2 years later. Really not something we'd expect with standard cytotoxic therapy. If we look at the 2-year survival rate, for example, between 14 and 26% of heavily pretreated small cell lung cancer still alive at 2 years. Now, I wish that number were 80, 90%, but really with standard therapy, that number would be much closer to 0. These directly led to the approval of both nivolumab and pembrolizumab monotherapy in the third-line setting. Nivolumab approved based on CheckMate 032 with a response rate of 12%. So not that everyone responds, the minority of patients respond, but those that do respond do quite well. These responses are fairly durable with about 40% of the responses still ongoing at 18 months. Pembrolizumab also proved in the third-line setting a modest response rate, 19%, but the responses are durable. So it's not that everyone responds, most people don't, but those that do respond can do quite well. And then the third-line setting, we really had no significant options. Now these were important approvals. We had nothing available in the third-line setting. So to have any drugs approved as third-line for small cell lung cancer was really filling an unmet need. And there's a subset of patients that get tremendous benefit. In fact, these are potentially transformative drugs. But in the third-line setting, unfortunately, there's quite a bit of attrition for small cell lung cancer. Here's some data out of Germany looking at patients with small cell lung cancer who received therapy. Of all those who received treatment, only about 1 in 5 get any third-line therapy. Are these attrition numbers in line with what you're seeing at your center?
I think somewhat. I think the first line definitely, but I think the second and third actually were probably much lower than what the literature shows. And I think it really kind of speaks to the healthcare disparities that we see in our patient population that we serve. So I think we'll talk about that a little bit later in my side of the lecture.
I agree that this is sort of a best case scenario, but this is a cancer that moves fast. And generally, most patients are only going to get one shot at treatment. And yet when we look at immunotherapy, when we think of that tail of that curve, you've got some people that are alive 2 years later for heavily pretreated small cell lung cancer. These are potentially transformative agents, and yet it'd be a shame to deprive that patient that would get that long-term benefit, alive for many years, to deprive that patient of the opportunity to get these agents. But if you reserve them for third-line use, most patients won't get the opportunity. So how do we increase the impact of immunotherapy? We try to move it up. And really the trials that have changed the paradigm for small cell lung cancer have been the first-line studies. The first trial to release reports in September 2018 was the Empower 133 trial. This was a randomized, double-blind, phase 3 placebo-controlled trial for patients with untreated extensive-stage small cell lung cancer. It included patients with brain metastases if they were treated and a good performance status of 0 to 1. All patients here receiving standard carboplatin, AUC5 on day 1, and etoposide, 100 milligrams per meter squared, days 1 through 3, for 4 cycles, and a 1-to-1 randomization of concurrent atezolizumab at a flat dose of 1,200 milligrams or placebo given on day 1. After the completion of 4 cycles of therapy, patients would then continue atezolizumab or placebo until progression or loss of benefit. The primary endpoints here, overall survival and progression-free survival.
So I have a lot of questions here, Stephen. Since I think you were involved in the trial design probably. So one, why was cisplatin not allowed in this clinical trial? And then also, I think we can talk about this a little bit later, but supportive care in terms of growth factor support, how was that actually allowed in the clinical trial? And then also one last question. I know the patients that were included were asymptomatic brain metastases or they were treated brain mets. Is that right?
Only treated brain mets.
Okay. So and I guess what my question always is was there a difference between patients who received immunotherapy and had brain mets versus patients who didn't receive immunotherapy? So it'd be interesting if you had seen any differences there.
Sure, so lots of great questions. Let me take the platinum first. We know in our practice that we consider cisplatin and carboplatin fairly equivalent in terms of efficacy. There was an impression early on by many, myself included, that cisplatin probably had higher response rates, but maybe no difference in survival. But we know now from large single-patient meta-analyses like the COSIS meta-analysis that not only is there no difference in OS or PFS, actually no difference in response rate. This is a very sensitive drug to chemotherapy. But response is not the endpoint we're looking for. Response rate, PFS, we've actually had many drugs that have improved response rate and that have improved PFS that just never translated into a survival benefit. And so when we look at the history of small cell lung cancer in trials, this is really where drugs went to fail. Where at every ASCO we would see a failed phase 3, a negative trial. And one thing that we noticed when we looked at these studies as we were designing this trial is that often there were subsets of patients where there were stronger signals. What we wanted to try to do with this trial, really trying to get the first positive trial in 40 years, what we really wanted was a clean trial, a trial with very homogeneous patient population. So we wanted to eliminate as many variables as we could, control for everything, have the only variable be the immunotherapy, and that'll really tell us, is this drug working or not? And there are many other questions that we could ask, but first we needed a win. First we needed to show that there truly was an impact. Then we could further refine it and adapt it based on our clinical practice. So when we look at cisplatin or carboplatin, practice patterns in the US and really in the world tell us most are using carboplatin. We didn't want to have to stratify for choice of platinum, and we didn't want differences in the outcomes to be reflected of platinum choice, so we made a choice. And majority rules here, we went with carboplatin. If we had allowed cisplatin, a small concern that we potentially had, and it turns out this is probably not true, but let's say we gave cisplatin and then cycle 2, someone had nephritis, an elevation in creatinine. We may attribute that to cisplatin, which we know is more nephrotoxic, but you wouldn't be able to say for sure that it wasn't due to an immune-mediated nephritis. And so based on that, you would have to hold treatment, whether it's atezolizumab or placebo. And what if that was one of those patients that was really going to make the difference, that was really going to show that response? We wouldn't want to hold that because it would only take a few patients to turn a positive trial to a negative trial. So to make it clean, we kept carboplatin. In practice, would I feel comfortable substituting cisplatin? I really don't see any difference there. But the study was carboplatin alone, did not allow the choice. And based on that, some institutions chose not to participate. But we wanted to keep a very clean study. Same with brain metastases. We know in practice that if someone has asymptomatic brain metastases, we won't pause for radiation. That this is a disease that won't wait. We'll start with chemotherapy, often get a response in the brain, and do radiation later. Asymptomatic brain metastases, should we have included them? We wanted to, because that would reflect our practice, but again, that's more heterogeneity. And what I would consider an asymptomatic brain metastasis, or what you may consider, might be different from someone in another country. Maybe someone who doesn't have access to MRI is using CT to screen things. So keeping in mind this is a phase 3 global trial, we wanted to account for some differences in practice and really just take out any variables as low risk as we could. It meant that it would take longer to accrue, but we would rather do that than really risk it with different variables. So only treated brain metastases, only carboplatin, only 4 cycles, no options for 4 to 6. Again, trying to keep it clean, no variables. Now, your question is an interesting one. Do patients with brain metastases fare differently? And I suspect that they would have, but this study did stratify for presence of brain metastases. So they were evenly distributed, and we didn't really see any differences in patients who had or had not brain metastases in the study. It was a minority of patients, though. And that's not truly reflective of our own practice, in part because when I had the study open, if I had someone with many asymptomatic brain metastases, for that person to qualify for this trial, I would have to do radiation and then begin treatment. Often I don't accept that type of delay. So if I had seen that patient in my practice during that time, I wouldn't enroll them on the trial. I would simply treat them with standard of care chemotherapy at the time because I thought the wait would be detrimental to their health, a little too risky. And that's reflected in the patient population where the incidence of brain metastases in this study was actually quite low.
One of the interesting things that I had noticed was the grade 3 and 4 neutropenia. Even though you would anticipate that carboplatin would have more neutropenia versus cisplatin, but when we look at the grade 3-4 neutropenia versus the Caspian trial, there was actually no difference. So it's actually in really interesting perspective.
Yeah, it really is. And I think that when we look at historic rates of febrile neutropenia, they were lower in this study than we would have predicted from previous trials. And that may have to do with sort of better overall care. To answer your question about the use of growth factor, it was not permitted with cycle 1 of this study. Secondary prophylaxis was permitted, but not primary. And part of it is because we were moving quickly with this. We didn't actually have safety data for this combination before the trial started. So this is one of the few studies that's actually a phase 1/3 trial to really gather some safety data on the first patients before we finished accrual. But we needed to capture those rates. And you're right, while neutropenia was common, febrile neutropenia quite rare. So in this study, looking at the impact of adding atezolizumab, the Pdl One antibody, to chemotherapy, the primary endpoints here were progression-free survival and overall survival. And this was a positive trial. the first in over 4 decades, meeting both of its primary endpoints, showing an improvement in progression-free survival with a hazard ratio of 0.77, and importantly, an improvement in overall survival, improving the median from 10.3 months to 12.3 months, the 1-year survival rate from 38% to 52%, and a hazard ratio for death of 0.70, or 30% reduction in the risk of death. When we see these survival curves, I appreciate that I'm not showing you a hazard ratio of 0.1, that I'm not showing you a 90% 2-year survival. But remember the context. This is a disease where we've had no advances since the 1970s, where we have tried and tried again to improve survival and have consistently failed. So to have any impact on survival really is a victory, and there's a clear improvement here. Now, when we look at these survival curves, many were quick to point out that towards around 18 months, they seem to come together. But this original graph from the original publication had a median follow-up of only about 13 to 14 months. With more follow-up, as was presented at ESMO, we saw that at 18 months there's a clear separation. In fact, the difference between the atezolizumab and placebo arms in terms of survival at 18 months really the same as at 12 months. So we see a consistent benefit over time. We'll continue to follow these patients to really look at the long-term impact. Importantly, the addition of atezolizumab improved progression-free survival and improved overall survival, but didn't significantly worsen toxicity. Now, while the rates of grade 3 or 4 adverse events were quite high, they were similar between the two arms, primarily chemotherapy toxicities. And as you mentioned, Bhavesh, neutropenia, leukopenia, even thrombocytopenia, these are often paper toxicities that don't have a lot of clinical impact, things that we expect with chemotherapy that we have gotten used to managing in treating lung cancer, often things that resolve on their own. The febrile neutropenia rate, quite low. And a surrogate, just for tolerance of the atezolizumab, we look at delivery of chemotherapy. And patients receive a median of 4 doses of carboplatin, 12 doses of etoposide, or 4 full cycles, telling us that the addition of atezolizumab improves outcomes without sacrificing our ability to deliver 4 full cycles of chemotherapy. Based on the survival, the efficacy, and the favorable safety profile, atezolizumab was approved as part of first-line treatment for extensive-stage small cell lung cancer in March of 2019. It has since been approved by the EMA and several other regulatory authorities across the world and remains an NCCN Category 1 preferred option. We waited over 40 years to see some improvement in the frontline setting for survival. We waited less than a year for the second improvement, which was the Caspian Study. Slightly different design here. This trial was an open-label, 3-arm study looking at standard chemotherapy, but here investigators had the choice of cisplatin or carboplatin and had the choice of 4 to 6 cycles and had the option for prophylactic cranial irradiation. 1-to-1 randomization of standard chemotherapy. The first experimental arm was the addition of the Pdl1 antibody durvalumab to chemotherapy. Again, investigator choice of platinum, but in this arm, it was limited to 4 cycles and no PCI was permitted. The final randomization was to a combination of durvalumab with tremelimumab, an anti-CTLA-4 antibody, also with chemotherapy, only 4 cycles and no PCI permitted. In both of the experimental arms, the maintenance treatment was durvalumab, so tremelimumab not given as maintenance, and that was given every month, whereas in the chemotherapy observation alone, and the primary endpoint here was overall survival. So some slight differences in study design here.
So I guess the slight differences is that they're allowing cisplatin, and then just in regards to the brain mets, correct? Is that the slight differences? And
so some slight differences here, as you mentioned, you had a choice of cisplatin or carboplatin. In the control arm, you could go up to 6 cycles. PCI was a little different, the use of PCI in these different arms. And you're right, asymptomatic, untreated brain mets were permitted in this study, which is different from the Empower 133 trial. So when I look at the study design overall, there are more variables here, which we were worried would cloud interpretation of the study. But when we saw the results, we were quite assured this was a positive trial, improving survival, and looked strikingly similar to what we saw with atezolizumab. Here we see the Kaplan-Meier curves for the addition of durvalumab to chemotherapy, and we see an improvement in survival. Hazard ratio here, 0.73, and improvement in the 1-year survival rate from 39.8%, 53.7%. The addition of durvalumab improved survival. And despite all these differences, these small differences in study design, these survival curves almost overlap with atezolizumab. And in my mind, these two studies really reinforce each other, showing that when you add a Pdl1 antibody to platinum etoposide, you see a modest but significant improvement in survival. With more follow-up, that overall survival benefit has persisted. Here we see more recent data from ASCO 2020, showing the hazard ratio here 0.75, and separation of those curves maintained at 12, 18, and 24 months. Now, you'll recall this study did have a third arm looking at durvalumab with tremelimumab during induction, followed by durvalumab maintenance. And that study, as we learned at ASCO 2020, that arm was not positive. The addition of durva plus tremi did not improve survival compared to chemotherapy alone. Hazard ratio here 0.82 with a non-significant p-value. While the curves do separate as they go further out, they largely overlap. And if we look at these three curves together, you can see durvalumab in dark blue clearly superior to chemotherapy in red, whereas the durvalumab plus tremelimumab arm really falls behind at the beginning and only catches up to durvalumab after about 18 months. I think that we both know the addition of CTLA-4 inhibitors in this population does add toxicity. If you look at serious adverse events, the addition of durva-tremi is about 45.5% compared to only 32% with durva, which was comparable with chemotherapy alone. Adverse events leading to discontinuation of treatment. Durva chemo, pretty similar to chemo alone, but you double that when you add durva-tremi. 20%, over 1 in 5 patients stopping therapy due to adverse events with the durva-tremi. Clearly a more toxic regimen. And that toxicity simply didn't pay off in terms of improving survival. And so what we're left with after the results from Caspian is an approval for the addition of durvalumab to platinum etoposide chemotherapy. That was approved in March 2020, but tremelimumab not an approved agent in this setting. And this is also an NCCN Category 1 preferred option. And so as of today, our standard of care has changed. For patients with extensive stage small cell lung cancer, chemotherapy alone is no longer a preferred treatment. It is chemotherapy platinum etoposide with durvalumab or with atezolizumab, both FDA approved, both showing a very comparable improvement in overall survival. However, there were questions that were also asked, what about the other immunotherapy drugs that we use in lung cancer and in small cell lung cancer? And we saw 2 other randomized trials at ASCO 2020, which were highly anticipated. The first was KEYNOTE-604, which looked at pembrolizumab. Now, pembrolizumab is a drug that really has taken market share in non-small cell lung cancer. It's a very active anti-PD-1 antibody. KEYNOTE-604 looked at the addition of pembrolizumab to chemotherapy. In a very straightforward design, patients receiving choice of platinum with etoposide and randomized 1-to-1 to receive concurrent pembrolizumab followed by pembrolizumab or placebo maintenance. Looking at dual primary endpoints of progression-free survival and overall survival. And Dr. Charlie Rudin presented these data at ASCO. What we saw was a modest improvement in progression-free survival with a hazard ratio here of 0.73, but the study did not improve overall survival, which was somewhat of a surprise. While the hazard ratio was 0.80, it did not cross the predetermined threshold for statistical significance. The KEYNOTE-604 study negative for survival. Pembrolizumab improving progression-free survival, but not improving overall survival, which to us was a bit of a surprise.
So I have a question here, Stephen. Based on these results, would that change your practice in using pembrolizumab for second-line therapy because of these first-line results?
So that's a good question. I understand what you're saying. I want to be sure that the audience doesn't misinterpret. If someone had progressed on immunotherapy in the first-line setting, progressed on durvalumab or atezolizumab, I wouldn't use pembrolizumab in the second or third-line setting. Again, second-line approval only for sort of MSI high. I wouldn't use immunotherapy after progressing on a Pdl1 inhibitor. To me, those are pretty lateral moves. I don't know if you agree with that.
Absolutely.
But if someone had not received immunotherapy as part of their frontline treatment, would I still consider pembrolizumab in the second or third line setting based on the negative KEYNOTE-604? And to answer that question, I would. It is clearly an active drug. The study did not meet its survival endpoint, but there was a trend. The survival curves look comparable, and the degree of benefit was comparable. And I suspect this is more of a statistical design, trial design failure than an actual failure of biologic activity. I think when you add these checkpoint inhibitors, you see some modest activity. This study was negative, and in my mind, should not lead to approval, wouldn't change my standard of care, but it's still an active drug. And in fact, if you showed me that a pembrolizumab combination outperformed pembrolizumab with chemotherapy, I would still accept pembro chemo as a control arm. I still think that's a reasonable comparison. I'm not using that. It doesn't change my standard of care. I certainly wouldn't explore off-label use when I have drugs that are approved in the phase 3 setting, but I think it's still an active drug, and I'm very comfortable using it in the second or third line setting for patients who hadn't previously received immunotherapy. In fact, if you'll allow me to sort of commit a faux pas here and maybe show a cross-trial comparison, which is absolutely not statistically valid, but what you'll see is that the results are pretty comparable. The median survival numbers between the atezo and the durva and even the pembro arm, a comparable effect when we add a PD-1, Pdl One inhibitor. And while the numbers are a little bit lower for 604, I still think there's an effect there. One question I get asked, is it really the difference in PD-1 or Pdl1? The two positive trials were durvalumab and atezolizumab, both Pdl1 inhibitors. The negative trial was pembrolizumab, a PD-1 inhibitor. It's really something about targeting Pdl1. And it is possible. The expression patterns are actually quite different in small cell versus non-small cell. However, we also saw at ASCO a trial led by Dr. Tiziana Leal, that the EA5161 study. They looked at nivolumab, another PD-1 inhibitor also approved for small cell lung cancer. And this trial took patients receiving any platinum plus etoposide and randomized to receive nivolumab or not, followed by nivolumab maintenance or observation. This is an open label randomized phase 2 trial showing a survival benefit. The addition of nivolumab improved PFS and improved overall survival, and it was the same degree. It was a hazard ratio of 0.73. The curves, again, look very similar to what we saw with atezo and durva. So to me, the immunotherapy drugs have this consistent effect. I think they're producing a similar effect. In a world where we don't have randomized phase 3 trials showing a survival benefit, I might consider the use of nivolumab, but here I wouldn't consider off-label use. I see some effect. It's an active drug. Our standards, though, are those determined by the randomized phase 3 trials and the FDA approvals of durvalumab and atezolizumab. And when we look at these Kaplan-Meier curves all together, we do see fairly consistent benefit with the addition of a checkpoint inhibitor to chemotherapy, improving outcomes. A question I get asked a lot, and this comes up, probably the most frequent question I get asked, is can the initiation of immunotherapy be delayed? Do we need to give it up front, or can we wait till longer? And part of the reason this comes up is when you look closely at those Kaplan-Meier curves from Empower 133, from Caspian, and even from the nivolumab studies, they don't really split until after about 6 months. And so a lot of questions I get asked is, can we finish the chemotherapy and then use immunotherapy later, save immunotherapy? It's active, but do we need to give it up front? And one of the reasons I get asked this question is a lot is because patients present often very fulminantly, and at least in my institution, are often hospitalized at the time of diagnosis. It's not uncommon for us to start chemotherapy as an inpatient. Is that true at your institution as well, Bhavesh?
Yeah, absolutely. I think many of the patients that actually present with small cell lung cancer, they have SVC or spinal cord compression or some type of oncologic emergency where they need to be started on the inpatient side. And my question was going to be that does your institution actually administer immunotherapy with the first cycle or not? Because this actually also kind of fuels the fact that you can probably put that immunotherapy off for the next cycle or when the patient's outpatient, because there is definitely this cost that is incurred to the institution where it's not covered by the DRG, and unfortunately the patients may have to end up paying for that. So there's definitely a question that arises frequently about immunotherapy, especially because we have this in the front line.
So I know that every institution's policies are a little different, but the use of atezolizumab in the inpatient setting really would not be approved by our own internal committee, primarily due to cost. And that's not a decision that I would ever fight. If someone is admitted inpatient and I'm worried about the patient incurring that cost, I don't need to give the atezolizumab with the first cycle. In the outpatient setting, I do. But in the inpatient setting, if I'm giving chemotherapy for someone who's presumably quite ill because they are an inpatient, I'll finish that chemotherapy, that first cycle, and if they improve to the point where they can be discharged, I'll then continue the immunotherapy with subsequent cycles, not waiting until progression, not waiting until they complete chemotherapy. I do want to give it concurrently as the trials did, but I feel comfortable waiting until cycle 2 if the circumstances are necessary. But that's a very relevant question because the medicines certainly do have their own cost. But I wouldn't want to wait. I wouldn't want to save it. That's a strategy that often doesn't work out as we planned. And in fact, in small cell, we have some of that data. First, we know there's a lot of attrition, that a significant number of patients won't make it to second line. Even fewer will make it to third line. So if I'm saving that drug in my pocket, and I promise that I'm going to use that drug at progression, that is a promise that more often than not, I won't be able to keep. But if we look at immunotherapy in the second line setting, the results are surprisingly somewhat disappointing. The Checkmate 331 study was a randomized phase 3 trial for patients with relapsed small cell lung cancer who had already received platinum, looking at second-line topotecan or amrubicin in parts of the world where that was approved versus nivolumab monotherapy. So here we have an active immunotherapy drug compared to topotecan. Now, topotecan has sort of, I think, a lousy reputation. It is the FDA-approved drug in the second-line setting, but it doesn't have a great schedule, right? Days 1 through 5. It is a fairly toxic treatment, and I think a lot of investigators, at least at our institution, don't like giving topotecan just because of the toxicity with it. And despite the low bar of topotecan, nivolumab was not better. This was somewhat of a surprise, but there was no difference in overall survival. The 1-year survival rate's almost identical between nivolumab and topotecan, and progression-free survival strongly favoring chemotherapy. Here, that immediate drop before the 3-month mark that you see in that Kaplan-Meier curve for PFS, that very scary drop straight down, that was the nivolumab arm. In an unselected population, in the second-line setting, nivolumab was not superior to topotecan and really was not approved in the second-line setting based on this. This was somewhat surprising to us, but we also realized that when small cell lung cancer relapses, it is different. Small cell lung cancer is responsive to almost any cytotoxic you give. It's really unique in that you can get a response with many different agents, but the responses are fairly transient. And when they relapse, they're different. They don't really respond to as many treatments when they come back. They're a much more difficult cancer to treat. So maybe waiting until relapse was a little too late. What about maintenance treatment? What if we complete induction chemotherapy, don't wait until progression, and give those patients immediately immunotherapy? And this was the Checkmate 451 study, where after chemotherapy, patients who had not progressed received either nivolumab alone, nivolumab plus ipilimumab, or placebo. And interestingly enough, the addition of nivolumab, ipilimumab as maintenance did not have an impact on survival compared to placebo. So waiting until maintenance setting for immunotherapy was no better than not giving immunotherapy at all. And so these were quite surprising to me, but I'm not sure if you expected to see something different. I certainly did.
No, I definitely anticipated the same as you did.
So it tells us that when we add immunotherapy, atezolizumab or durvalumab, to first-line chemotherapy, we improve survival. If you wait until completing chemotherapy and then just deliver nivo-ipi alone, that has no impact on survival compared to placebo. And so it's hard to explain that. There's certainly plenty of theories. We could work out reasons as to why that might be the case. But in clinical practice, waiting until the end of chemotherapy to start immunotherapy is not a proven strategy. It's not an approved strategy, and in my opinion, not a recommended one. The only strategy that's improved survival is the concurrent use of first-line Pdl1, atezolizumab or durvalumab with chemotherapy. Now, I'm very comfortable with cycle 2 if someone's admitted for cycle 1, but I wouldn't wait until completion of cycle 4, and I certainly wouldn't wait until progression, where it's no better than chemotherapy. We see a clear benefit here, but these drugs we know also can induce some risk, and immune-related adverse events can occur with this. While overall, it's a very well-tolerated regimen, and generally patients feel better with chemotherapy because of the high response rates, because many of their symptoms are related to the cancer itself. Immune-related adverse events can occur. And these, I think, are of the utmost importance, not just in small cell lung cancer, but oncology in general. And Bhavesh, I think you and I have both worked on different strategies to try to educate our patients, our colleagues, as well as patient caregivers about recognition of these immune-related adverse events. Because bad outcomes that I see when I'm reviewing cases, reviewing charts, the bad outcomes are primarily slow recognition or slow action? Right?
Absolutely. I think, when you have those, prominent grade 1 or 2, and if you're not actually really identifying those and in a timely fashion, they could definitely be escalated to a much higher grade. And, I think we noticed in both the clinical trials that majority of the immune adverse events were basically thyroid hypothyroidism or hyperthyroidism. So, really kind of need to be on top of that. I mean, there was actually one patient death in one of the immunotherapy trials of hepatic toxicity. So there's definitely some long-term monitoring, some short-term monitoring, and education of all the stakeholders that are involved in managing the patients, really important.
What I tell patients is, with chemotherapy, we have a list of expected toxicities with targeted therapy toxicities. And where patients may notice something completely unrelated, we'll say it's probably not related. But kind of the default for immunotherapy is that anything new could be considered related, because our immune system can target any part of our body. And so anything new that happens, my default is I think it's going to be related unless I can find an alternate explanation. And really, head to toe, as this chart suggests, any organ can be affected with immune-related tox, and we've seen them all. The management for the immune-related toxicities really is immune suppression. Now, this is not like chemotherapy or targeted therapy where it's dose reduction. That's not an effective strategy. It's really stopping the therapy if needed and immune suppression, escalating those based on severity. And the one that we worry about the most when we're dealing with lung cancer is largely pneumonitis. Pneumonitis can go from 0 to 60 overnight. So if patients are newly hypoxic, have a new cough, new shortness of breath, that's something that we've taught our trainees, our nurses, our support staff that any new complaint, we got to take that very seriously. Those patients are getting CT scans, even through the emergency room if we need to. New hypoxia, you're getting a CT scan, we're staying late to see it, and if it shows pneumonitis, you're getting admitted to the hospital. And these are our patients that can decompensate very quickly. We have to have a healthy respect for the immune-related adverse events. And I'm not sure if you have a similar strategy at your institution as well.
Yeah, no, absolutely. I think pneumonitis is definitely a concerning aspect. A very small percentage of patients can have that, but we definitely inform our patients if they see changes from their baseline in their pulmonary function status, that they need to basically come to the clinic right away and not wait until their appointment next month.
No, absolutely. Now, fortunately, as you mentioned, they're rare. And I try not to, I'm not scaring patients off from the use of immunotherapy. I say these are rare, but it's important they know about that. So when they're feeling more short of breath, if they're having notable diarrhea, for example, that they're not waiting 3 weeks to tell us that they're calling overnight, that they're taking these seriously. But we've also had many efforts, at both of our institutions to educate our colleagues in primary care, in emergency rooms and other specialties to recognize these as possible toxicities, because the time course can be quite variable. While most will occur within the first 3 to 6 months, we can see new toxicities potentially years later. And it may be important for our anesthesia colleagues to understand that this patient may be at risk for adrenal insufficiency or an adrenal crisis, that these are toxicities that can impact really any part of medical care. And as we see more and more of these drugs used, those toxicities are going to become more and more pervasive in our day-to-day medical routines. Now, managing toxicities is clearly an important thing. We see overall the addition of atezolizumab and durvalumab to chemotherapy is safe. We don't see a significant increase in toxicities. We see an improvement in survival, and that's sort of where we are now. But where do we want to be? What we want is a bigger therapeutic window. What we want is a larger degree of benefit. And to do that, we need to identify who is getting that benefit. We see a tail to this curve. We see a subset of patients that are living for years, certainly living longer than they otherwise would with chemotherapy. We can increase the impact if we can prospectively identify who those patients are. And so as with any study that's showing improvement, we want a biomarker that's going to help identify who are those people more likely to benefit from this strategy, so we can ensure they get that treatment. And for others, we can maybe direct towards a clinical trial or try to better understand the biology of why they're not getting that benefit so we can overcome that. And biomarkers for immunotherapy are not perfect, far from it. But in non-small cell lung cancer, the best biomarker we have is Pdl One expression by immunohistochemistry. And so we looked at that in these two randomized trials in both Empower 133 and Caspian. And again, these trials reinforce each other. They show very similar things. First, generally, Pdl1 is negative in small cell lung cancer if you look at the tumor. We do see expression of Pdl1, but primarily on the microenvironment around surrounding lymphocytes. And in this trial, which was sort of the best circumstances, even in this study, most patients did not have samples that were evaluable, even for a simple Pdl1 immunohistochemistry. Again, showing that tissue specimens are very scant and very difficult to come by. Now, when Pdl1 was explored, whatever cutoff you used, whether you were above or below, it wasn't useful in discriminating who gets that benefit. All patients seem to derive benefit, high or low, from atezolizumab or from Caspian. And we even saw the same thing with pembrolizumab. The subsets based on Pdl One expression using the DACO22C3 clone didn't help predict patients. No utility in patient selection. The other biomarker we often use in non-small cell lung cancer is tumor mutational burden. Not a perfect biomarker either, in fact, questionable role even in non-small cell lung cancer, but in small cell lung cancer we did look at blood-based TMB in the Empower 133 regimen and tissue TMB in the Caspian regimen, and again, whatever cutoff you used, whether you're above or below, outcomes were better with immunotherapy. So for Pdl One expression, for tumor mutational burden, no utility in patient selection. There is still a subset of patients that are getting benefit from immunotherapy. Clearly that subset exists. We just don't have the tools to identify who those patients are. There's a lot of work being done now to try to advance biomarker work, and some of the work done primarily by Dr. Charlie Rudin at Memorial is looking at transcription regulator expression as different subsets, biologic subsets, looking at things like ASCL1, NeuroD1, YAP1, PAL2F3 as different biologic subsets based on their expression of certain transcriptional regulators. And we know that this does represent some slightly different biology, and importantly, these can be tested with immunohistochemistry. So we don't need large tissue specimens for next-gen sequencing. We can do IHC, identify these different subsets, and if there is one subset, like the YAP1 subset, potentially that subset could derive most of the benefit from immunotherapy. Maybe the other subsets are not getting that benefit. That could be used to help direct therapy where it's supposed to go and improve that signal of benefit, delivering treatment where it's most needed. We're quite a ways from validating that, from showing that that is the case, and there are a lot of challenges with that, including the fact that one tumor specimen can be positive for multiple subsets at once. So it's not as clean as the driver mutation status we see in non-small cell lung cancer, but it clearly is a start. And so, what we've talked about so far is that small cell lung cancer is a very lethal cancer. It remains so, disproportionately lethal. But we do have a new standard of care, that the addition of atezolizumab to carboplatin etoposide, the addition of durvalumab to platinum etoposide improves survival, and these regimens represent our current standards of care. Second-line approaches, maintenance approaches have not had the same impact. The best treatment we have, the only intervention that improves survival, is really that concurrent first-line use.
So we just heard Dr. Liu talking about all these amazing studies and innovation with immunotherapy. So my objective, second half of this lecture, is to talk about how to integrate this in a managed care perspective. The challenges and the practicalities from a health system, from a managed care perspective. So hopefully I can share some of that. As I was kind of looking at doing this lecture, looking at the market, I came across this article that was published in Nature 2020 just recently, a few months ago, which was done by a life science company from London, and they were actually evaluating the small cell lung cancer market, and they identified that between 2018 and 2028, we would see an increase in therapies across the 7 global markets, US, UK, Europe, to about $3.8 billion in expenditure due to the innovation. About 85% of that is forecasted to be due to PD-1 inhibitors. So really interesting analysis, and I thought it was nice that they actually broke down in terms of the different therapies that are being considered for this analysis across the globe. So interesting perspective from a life science company if you wanted to follow that, but it really kind of also gives you from a managed care perspective that immunotherapy is definitely here to stay, and there's more innovation coming in small cell lung cancer. And I guess one of the other questions I had as I was kind of doing this lecture was, why was small cell lung cancer so behind on the path to innovation? So, I kind of did some digging and identified, obviously for 20, 30 years, I've been practicing for over 20 years, so I know there's definitely been poor understanding of the disease biology. And of course, there's lack of funding, lack of access to biospecimens. And we know that there's all these repositories and access to biomarkers for non-small cell lung cancer, unlike small cell. And there was just not a great collaboration between international working groups and local working groups and designing clinical trials specifically around small cell lung cancer. So in 2012, Congress actually passed a regulation that was called Recalcitrant Research Act, which basically forced NCI to identify 2 recalcitrant tumors, which one was pancreatic and one was small cell lung cancer, and really focus efforts to identify ways to improve these diseases. Because if you look at the 5-year overall survival was less than 20%, in small cell lung cancer was actually around 8%. So there was a significant room for improvement in this malignancy. So basically, a group of experts came together, about 50 experts, and they put together 5 recommendations for the NCI to focus research around, is basically developing better research tools to study small cell lung cancer. So, and then also develop comprehensive genomic profiling, just like we have done for non-small cell lung cancer, develop new diagnostic approaches. And then we know that small cell lung cancer is a pretty highly responsive malignancy to chemotherapy, but there's this really fast emergence of resistance to chemotherapy and radiation. So really looking at the underlying mechanism behind that. So if we look at kind of the progress in specifically in some of these recommendations, as we know, there's actually really not too much in regards to driver mutations in small cell lung cancer. So obviously we don't have many targets or any targets in small cell lung cancer like we have in non-small cell lung cancer. And I wanted to know, Stephen, I don't know if you have anything to add to that, but that's just really an interesting perspective, right?
Yeah, I think that there are a lot of reasons that you could explain it. One reason is that small cell lung cancer moves very quickly. For non-small cell, if we have a patient who presents, we get a biopsy, there's not enough tissue for all these in-depth analyses, we'll send that patient back for another biopsy because it so dramatically changes our treatment plan. It's so important to know. And it's partly the rebiopsy and those large biopsy specimens that led to a lot of advances. But small cell moves very quickly. Patients often can't wait for rebiopsy. It's usually kind of a central tumor, so diagnosed by bronchoscopy or fine needle aspirate. So we'll have a few cells, enough to make a diagnosis of small cell, not enough to do any meaningful work. And because the chemotherapy is old, comfortable, sort of familiar chemo, we're very quick to just kind of reach for it. And then you get that initial response, and you get a good response. When it comes back, it's a little different, but we've been having troubles sort of understanding that initial de novo small cell, really studying it more. And I think that's really led to a lot of the inequities in care that you mentioned.
No, thank you for sharing that. So, obviously we know there's this explosion of immunotherapy, and as you can see, there's at least 10 randomized controlled trials that are either ongoing or completed in this arena. So there's definitely a huge amount of innovation that came through because of all these initiatives that were initiated a while back. In regards to, as we talk about managed care, I think one of the most important aspects is always to talk about cancer-related healthcare disparities. We live in times where we've kind of really identified these in especially COVID has kind of brought light to a lot of these disparities. We know that, African Americans and patients who are Hispanic descent are impacted by these healthcare disparities and of COVID. And AACR actually recently released a report which basically talks about these disparities and highlights them in every single malignancies. And looking at the population that we have is so broad, and there's such a variety of shouldering of cancer that happens between these different varieties of populations. So, for example, we in the AACR report, we identified that about 100% of African American patients are actually at risk. They're 100% likely to be risk of dying versus their white counterparts. Patients who have lung cancer in Kentucky are 3.5 times more likely to die of lung cancer versus patients who are diagnosed with lung cancer in Utah. And patients who are bisexual actually have a higher incidence of malignancy, about 70% higher incidence of malignancy versus patients who are heterosexual. So there's huge disparities in burdening of cancer across our patient population. And I think one of the things that we had talked about is even having a specific insurance actually can be disadvantageous to you, where we know commercial patients actually fare better versus patients who have Medicare and Medicaid due to access issues. So there's definitely a lot of things that we need to do around cancer health disparities, and I think it kind of fits nicely into managed care setting too. And then I think I wanted to kind of pull really kind of the small cell lung cancer disparity. So there was a very large database from 2013 that actually revealed that about patients who were uninsured were 35% less likely to receive chemotherapy and 25% less likely to receive radiation. And we know the combination approach is definitely the more beneficial that these patients can have. And it was really kind of bringing out the fact that, these patients are actually not getting the care that is standard of care for this specific disease. And I want to know if you actually see this, across the practices that you've actually been in contact with, if you've seen this in your practice with this patient population.
I think we all have, and it's something we don't talk enough about. We know from many studies, including the ones that you've mentioned, that the disparities in care directly impact outcome. And it's not surprising, but it's also not acceptable. And we really need to try to relieve a lot of these barriers, and we can. Where I see it impacting it is really every step of the way, whether it's slower to get diagnosis, whether it's not being able to come in for a biopsy or bronchoscopy, maybe because you don't have transportation to get there, maybe because you don't have the ability to take a day off work to get this bronchoscopy because you can't afford to sort of miss a single paycheck. And I think as institutions, it's our responsibility to identify what these barriers are and do everything we can to eliminate them. And it's hard work, but it's important work. And we can't allow sort of the income level or where you live determine your outcomes for cancer. I mean, that's just not acceptable in this day and age. And we do see it in the DC area. We have parts of DC that are underserved, where there are different barriers to care that we're working hard to try to eliminate it. And I know you see this in Boston as well. You must.
No, absolutely. I think, we've definitely kind of started the journey on the social determinants of health a long time ago, and where we actually have a process in place where we know that food insecurities, housing insecurities, these things also drive how a patient fares in their malignancy. So, if a patient's identified in our system where they have food insecurity, they could actually get a prescription and they could go to our food pantry and they could get food for their entire family. And we actually do about 600 prescriptions a week for patients with food insecurities. And similar to that, we've kind of developed this housing insecurity intervention too. So I think, like you said, everybody needs to kind of play a role in supporting these types of disparities in patients with malignancy. So I think when we talk about the economic burden of small cell lung cancer, we know that this is an aggressive cancer, and there hasn't been a lot of resources that have been dedicated to kind of really understand what the total cost of care impact is of this malignancy. So I think, I wanted to kind of highlight the fact that there is indirect costs and there's direct costs. That, direct costs is related to hospitalizations, the drug, the radiation, the surgery, the diagnostics. All of those things are taken together, and we have very little information in terms of what happens to these patients with chemotherapy versus what happens to these patients now when we're adding immunotherapy to their regimen. So I think that you really wanted to highlight the fact that there needs to be some partnership between pharma and payers to really develop some models that can help us, because we know that as we are looking at moving away from fee-for-service model to value-based environment in the US, these are the things that are going to help us in terms of adopting these innovative therapies and understanding the total cost of care, because we are all kind of getting into those OCM, ACO models where value is more important than volume. So as I was talking about the cost, I think from a formulary perspective, as a payer and a provider, you're looking at cost of each therapy that you're utilizing. And then not only do we look at the cost of the therapy, but we also look at, is this therapy going to increase the number of admissions? Is it going to increase ED utilization? So all of these things need to be factored in, and not just the cost. And sometimes it's deceiving what we see in terms of the pricing. So I just wanted to give this example where a lot of times where providers may not be aware of, where Nivolumab looks like it's more costly for the first cycle or the first 4 cycles, whereas Atezolizumab is actually looks like it's less costly for 4 cycles. But as you look beyond that, based on the dose and the frequency, it actually looks like it actually costs more for a health system to use Atezo versus Nivolumab. So I think it's important to look at this from an annual perspective, overall global perspective, and this is important to healthcare providers and payers who are actually paying for these therapies. That if I can save $10,000 on a patient with small cell lung cancer every year, of course I'm going to actually prefer that therapy over another. So I think it's important for even pharma to be aware of these differences that drive some of these formulary changes in health systems and payers. The other aspect is reimbursement consideration. So of course payers have a fee schedule. Health systems actually absorb that fee schedule. And then who's the biggest payer? Medicare is the biggest payer, right? So if I'm looking at Medicare patients and I'm looking to see, oh wow, I'm spending $10,000 more, that means that patient's actually sharing that $10,000 in cost sharing, 20% of that. So I think that's another perspective that providers and payers may consider as they're using these therapies, is that how much is it going to cost the patient, and can I use something that's lesser costly to the patient? And then the other things that also drive some of these decisions is having a new technology assessment payment. This is something new that came about. We talked about how some of these patients are going to be in the hospital, admitted to the hospital, starting their therapy in the hospital. So it was nice that there was this new technology assessment payment, which basically provides some reimbursement for using immunotherapy in the hospital from Medicare. But that's the key, it's just from Medicare, not from Medicaid, not from commercial payers. So I think you need to understand that. And then there's also a limitation in the reimbursement. So it's not like you get fully reimbursed based on the acquisition cost. I mean, that would be great. If I was getting reimbursed 100% of what I was spending, I would have no problem using immunotherapy in the hospital for any patient. And then the other limitation is that this is only for small cell lung cancer. Of course, we know that these drugs are approved for other indications. You will not get reimbursed for NTAP for other indications in the inpatient side. And then there's a very complex way of coding and billing, which is really the biggest hurdle that a lot of institutions have, is you have to have this secondary procedure code on top of the DRG, and then you have to have this specific service code and a review code, and then this ICD-10 DRG code that's tied to that. So you can imagine this is not something that your finance department is really well versed on for every single NTAP. So definitely a complexity in managing this drug in the inpatient side. But if you have the resources and have appropriate guidance, I think that you can definitely get some type of payment from the payers that do pay for it. I think if we look at kind of, I like you said, you're going to do a faux pas. I'm going to do the same thing with cross-trial comparison. Part 2. As you can see, there's an equivalency in these regimens. And then even if you look at compared to chemotherapy, like you said, it's not groundbreaking significantly. You have a 6-month difference in overall survival. So how do you justify the cost to the benefit that you see in these diseases? And I think, sometimes a lot of systems and payers are just looking at the overall survival, but not looking at the overall survival over time. I think that is what the key to immunotherapy is. And I think really payers need to really focus on going a little bit beyond the overall survival, progression-free survival, the median overall survival that you see, and that at that time point. So I think looking at having a difference in double the number of patients actually having a survival benefit, which we haven't seen in small cell lung cancer, and we know that immunotherapy can benefit some of these patients. So I think it just would not be justified not to offer this just based on the cost and looking at it from a cost-effective perspective. I think it makes sense to actually see that from both of the immunotherapies that have been currently approved. I just wanted to see if you had any perspective on that.
Yeah, I couldn't agree more. We're used to looking at medians, and for cytotoxic agents, for TKIs, I think there can still be some value in that. But for immunotherapy, the benefit is delayed. It's shouldered by a subset. And I think the real value for immunotherapy is landmark survival. And so how many patients are alive 2-3 years later? With immunotherapy in particular, these survival curves did not cross, but sometimes the curves cross, in which case your assumptions for hazard ratio go out the window and the number is sort of meaningless. And so for me, the value of immunotherapy, it's not response rate, it's not a better progression-free survival, it's are more people alive years later with the addition of immunotherapy. And for both these drugs, we see that is the case. You really look towards the right end of those survival curves for the benefit from immunotherapy.
I would love to see the 5-year survival like we saw in melanoma long term. So that'd be really interesting when that comes out. I think that we have these value-based frameworks and that are out there. So I think, the thought is that this would actually help providers and payers in terms of deciding, here's a value-based tool to identify more cost-effective therapies. So I just listed a couple of them. I'm not going to go in detail for all of them, but just kind of want to point out some of the things that I've noticed. So ICER, always has their analysis done, and especially in oncology. So they did one actually on immunotherapy for PD-1 in lung cancer, and their analysis basically came out saying that immunotherapy are overpriced and they need to reduce their price by 68% for them to have the quality adjusted life year that's $150,000. So nothing happens based on that. I mean, there is obviously not really oncology input. There's no long-term data that actually goes into that. So I think it's really hard to kind of utilize some of the guidance from ICER in regards to from a payer perspective and from a provider perspective in this value-based tools. I think ASCO, I'll have a slide on that, so I'll talk about that. NCCN has these evidence blocks, and Memorial Sloan Kettering has a tool where you can actually adjust, the provider can adjust the price based on the innovation of the therapy. So I think, going to ASCO, which is more oncology oriented, which makes sense, and they take into account overall survival, overall response rate, progression-free survival, and they provide a structured amount of points that you get for the benefit. And they actually have it broken down by adjuvant versus metastatic. And then, of course, there's points that get taken out for toxicity. But one of the limitations is that it doesn't incorporate cost into it. And I'm maybe simplifying it too much, but there is a lot of time that goes into actually calculating a score. So it's not really something that you can use while you're seeing a patient. Let me look at the value-based score from ASCO on this specific regimen. And then because innovation is so rapid that not all of the regimens are kind of in that framework to incorporate the model. So there's a lot of work that kind of needs to happen in regards to these models, but I think it's a start. I don't think that we should stop kind of not doing this. I think that we will probably eventually come up with a model that fits everybody, and that can be used by payers and providers to kind of say this is more cost effective and this is not more cost effective from a toxicity perspective, from a survival perspective, from quality of life. So I think we will probably get to that one day. But I think the other kind of subject I wanted to kind of introduce was value-based contracting. I think this has kind of been definitely something that we heard about. A lot of these rare disease drugs coming out, and payers are announcing that they're doing value-based contracting with many of the manufacturers. Of course, a lot of the contracts are never publicized, but there's different models. So one is that the manufacturer takes the risk, where they basically have a risk, and if they don't achieve that outcome, then they have to repay the payer or the provider. And then the second model is that the payer assumes the risk, and then they receive the discount if the product doesn't actually achieve the expected outcome. And then there's the other model, is the last one is basically a shared model where they're both sharing the risk. And I think this is probably the most appealing model, because it makes sense that if you're taking risk, it should be both-sided, right? It shouldn't be one-sided risk. So I think I wanted to, interest of time, kind of talk about one of the most publicized model that I've actually come across is bevacizumab. Actually has a model or a value-based, outcome-based contract with this health plan in Michigan. It's a very large health plan, over 1 million members, and they actually have a risk-based contract where basically we know how much bevacizumab costs. And this is actually the equation that they're using is publicized, but of course not the actual rebate or the risk that they're incurring. So let's say a patient had 6 months, we anticipate based on lung cancer trials that there's a 6-month median progression-free survival, and this patient only achieved 3 months. So there's actually that risk where there's a rebate that goes to the payer. If that member doesn't achieve that median progression-free survival. So really, really innovative and interesting. And believe it or not, this is still actually ongoing. And there's a data aggregator that's kind of like a middleman who actually gets the radiographic scans and assesses for progression and response to validate that for the contract. So very, very innovative. And I'm glad that it was actually publicized, because we don't actually see a lot of these great value outcome-based contracts that are out there. And I think if based on the cost of a lot of the immunotherapies and the degree of benefit, of course we're going to see pushback from many of the authorities. We've seen this with the NICE people. They're so nice on every single drug that gets approved. In January, they actually basically said they would not recommend Atezo for extended disease small cell lung cancer. But then July, things change where they're like, okay, we see a benefit in the ECOG performance stat of 0 to 1, and based on the agreement that they have. So obviously they actually negotiated an aggressive pricing for the drug to actually put the drug on formulary for the entire health system or healthcare system in the UK. So I think this is kind of the more extreme models that you have, where the government is negotiating the value-based or outcome-based contract. versus we could actually start doing this ourselves. So I think there's definitely a precedence of having some type of model that we can sustain this innovation. So what happened when the small cell lung cancer working group met in 2019? They basically are guiding NCI in terms of what there needs to be focus on. So that, here are kind of the recommendations from them in terms of where we need to focus on, and where the funding should go towards the type of projects that NCI should be sponsoring. And it's really kind of taking us to the next step, and that's why I wanted to kind of focus on the future pipeline of agents. We know that there is this push of these agents to more limited stage small cell lung cancer. Durvalumab and atezolizumab is being studied in the limited stage small cell lung cancer. Phase 3 randomized controlled trials that are being done in that setting. And I don't know if you have any comments about the Adriatic study, Stephen, but here's the opportunity for that.
I think that both the Adriatic and the NRG-LU005 study looking at durvalumab and atezolizumab for limited stage, I think those are going to be very important studies, because we know that these drugs are active in small cell. For limited stage patients with potentially curable cancer, we really need better outcomes. And this is combining what we saw in Empower 133 and Caspian with what we saw in Pacific, where when you use immunotherapy after chemoradiation, we see an improvement in outcomes. And I think that interplay is really setting it up for success in small cell. I expect both of these trials to yield positive results and really make a difference here.
The next molecule I wanted to bring up in the pipeline is Tergolumab. We saw some preliminary results in phase 2 in non-small cell lung cancer, where there was a significant benefit, and even patients who actually may be refractory to PD-1. So it's an interesting combination. It's actually being studied in phase 3 in small cell with atezo and Tergolumab, and also in non-small cell lung cancer. So really, I don't know if you have any perspective into this molecule, but would love to hear that too.
What you're referring to is the Cityscape study that looked at the addition of Tergolumab to atezolizumab, and we saw that it had a substantial benefit in that subset of patients that were Pdl1 high, which is probably because TIGIT seems to be co-expressed with Pdl1. So that subset of patients really seems to be deriving what could be substantial benefit, really expanding the role of atezolizumab and immunotherapy in those patients, both for non-small cell and small cell. In the Skyscaper trial, we'll see carboplatin, etoposide, and atezolizumab with or without tiragolumab. And so certainly look forward to seeing those results, but hopefully further improving outcomes.
That's great. Obviously, I'm sure I'm going to get your perspective on this, but Trilocyclip is this interesting molecule, which is a CD4/6 inhibitor, which we usually see being used in patients with, breast cancer, but this actually is being used for myeloprotective agent, where you're basically treating myelosuppression. So it's really interesting, and I wanted to get your perspective in terms of how this actually would fit in to the small cell lung cancer treatment algorithm, because obviously it all depends on how we currently utilize GCSF prophylaxis, and if there is any benefit of having this also added to it. As you can see, that there was definitely some benefit in the degree of severe neutropenia, duration of severe neutropenia in these patients. And I think I wanted to get your perspective, because obviously growth factor support has always been controversial in small cell lung cancer, and adding another agent to growth factor support, I just wanted to know what your perspective was of that.
I think supportive care is important, and we know that the chemotherapy regimen we use, the platinum etoposide regimen, carboplatin plus etoposide, is myelosuppressive. And I see value in avoiding neutropenic fevers. I see value in avoiding delays in treatment. But when we look at the 133 regimen, I think that maybe we're a little surprised that a lot of toxicities really didn't seem to have clinical impact. While you saw high rates, about 23% of patients developing grade 3 or higher neutropenia, the febrile neutropenia rate was only 3%, which is pretty small. And that's without really growth factor use. So I think that reducing neutropenia and leukopenia, in my mind, I'm not sure the value of that. If that is largely a paper toxicity and it's not having a clinical impact, I'm not sure reducing that will improve outcomes. The exception to that would be if it's important to preserve those lymphocytes, for example, to get your immune response. If really the likelihood of an immune-mediated anti-tumor response or long-term benefit is really predicated on preventing those cells from being damaged, then maybe there is a role for myelopreservation there. But for me, if the drug were completely free, I have probably no objections to using it. But I still need to really be convinced of the true value of adding that type of support in this setting.
No, I have to agree. I mean, obviously, as I had mentioned, the whole growth factor support is such a controversial aspect in small cell lung cancer as it is. If you look at, the NCCN guidelines, the recommendation is to use it for patients with curative intent and a febrile neutropenia incidence of greater than 20%. So even using it in small cell lung cancer, we don't use it in our practice. We use dose reduction, and there's nothing in the literature that I'm aware of that basically talks about having a relative dose intensity of 85% that's going to have better overall survival for patients with small cell lung cancer. So, I think that it's hard pressed for us to actually add more cost to already immunotherapy and other agents that we may be using to small cell lung regimens.
Now we follow the same procedures at our institution. Very liberal with dose reduction should we need that. This is a very chemosensitive tumor, and in fact, if you look at the platinum etoposide regimens throughout history, the doses in all of these studies are all a little different, just showing that it probably doesn't matter specifically which exact dose you're giving. I find that to be generally a better strategy. Secondary prevention I would handle maybe a little differently, but in the setting of no neutropenic fevers, I'm pretty comfortable with just modifying dose.
So in conclusion, there's been significant innovation in small cell lung cancer for a tumor that's recalcitrant. In the past 5 years, we've just basically seen a change in treatment paradigm. There continues to be focus on incorporating immunotherapy in earlier stage of the disease. Also looking at unique combinations of immunotherapy that are under investigation. So definitely we'll see kind of utilization of these drugs beyond resistance in small cell lung cancer. And it really kind of brings us back to the managed care perspective, how we're going to really need to understand the total cost of care models, the value-based framework for these types of agents, and really kind of, how do we adopt this innovation with the significant costs that we're going to be saying and create access for patients, because we saw that there was a huge disparity, right, in patients across various different patient population. So I think that as payers and manufacturers, I think we really need to work hard on developing these models further, because as you saw, there's a forecast of this continued growth of $3.8 billion over the next 10 years in small cell lung cancer space. So really looking towards a lot of innovation in this space. So I think it's time for a few questions. Let's take a look at some of the questions that have been submitted by our audience. One question is around, and this is for you, Stephen. How do you see immunotherapy biomarkers playing a role in the future in small cell lung cancer?
Yeah, I think that it's something we have to keep working towards. I mean, that's our goal. We know that a subset of patients is really carrying the benefit, and we can increase value if we can identify who those patients are to make sure they do receive that. And I could certainly envision a future where we would limit the use of certain medications like immunotherapy based on biomarkers to where they are going to provide benefit. We think of positive biomarkers. I also think we're going to start seeing negative biomarkers, where when we see a certain mutation or a certain set of biomarkers that predict a patient won't derive benefit, that we can really avoid delivering that drug, avoid the added costs, the risk for toxicities, and really explore alternate strategies. So both positive and negative predictors of benefit, I think, would be incorporated in the near future for small cell. It's been challenging, and I think you hit on some of the challenges, but they are things that we must rise up and really combat. So those are definitely coming, hopefully sooner rather than later.
Thank you, Stephen. So I think I'll take this next question. In your experience, what is the level of interest for outcome-based contracts among oncology products and manufacturers? Do you anticipate this changing in the future? Absolutely. I think that we've seen quite a few oncology product contracts. Of course, it's challenging to do contracts, especially with immunotherapy when you're looking at long-term survival. So it's definitely harder to do, but as Stephen had mentioned, there may be biomarkers, there may be patients who lose responses early. There is definitely things that you can be innovative and do these types of contracts, and we've kind of started to see this, especially in our payer side, with several manufacturers where we're dabbling into these outcome-based contracts more than value-based contracts. Thank you, everyone, and this concludes our presentation for today. I just want to thank Dr. Liu for all his insights and expertise in sharing all the data of small cell lung cancer.
Thank you for listening. Download materials and complete the post-test for instant credit at peerreview.com/TMR860. This activity is supported by an independent educational grant from AstraZeneca.